Our next speaker is Dr. Danny Tsai. Danny's an antimicrobial stewardship pharmacist at Alice Springs Hospital, also an academic lecturer and rural pharmacy liaison officer working at the Centre for Remote Health, which is a joint centre of Flinders University and Charles Darwin University. He's been working in Alice Springs for over 9 years with a passion for intensive care medicine, infectious diseases and Indigenous health. And I'm really delighted to have Danny presenting today on a study which was extremely interesting on POP-PK and ceftriaxone. But I'll pass over to you now, Danny, and you can share your findings.
Thank you very much for the introduction, Susie, and thank you for the invitation and for me to have this opportunity to have a chat with everyone about this study that we have recently completed. I literally just sent through my response to the reviewers this morning, so hopefully we'll get some good news soon. So this study was carried out by myself and my colleagues in Alice Springs and supervised and mentored by Professor Roberts and Dr. Susie Parker. So essentially, I live in remote Australia, and we look after a lot of Aboriginal and Torres Strait Islander patients in our setting. Unfortunately, due to socio-economic issues and various problems that we are seeing in this particular setting, we're seeing high rates of end-stage renal failure, high rates of infection, and high rates of infection-related hospital deaths in this population. So because we see a lot more people on dialysis, but then there are not as many PK studies looking into antibiotics use in the chronic intermittent haemodialysis setting. So we decided to look into it. So essentially, for everyone who is on a intermittent hemodialysis, or not everyone, but most people on hemodialysis, they would receive dialysis 3 times a week on a fistula, which is a matured, a vein, where that's got vessels that are strong enough where you can poke it 3 times a week, where you can actually perform dialysis through those veins. So there are cases where, whenever patients require IV medications, there are times that we actually just give those antibiotics or give those drugs 3 times a week rather than doing it daily. Because if you do it daily, you might, it means that you will have to accumulate the patients quite frequently. And you know that for the, renal patients, their veins are quite brittle, and their veins might be needed for vascular access need for fistula formations down the track. So these veins are life-saving. So the less that we play around with their veins, the better. So if we can do 3 times weekly dosing just at the end of the dialysis session, we might be able to prevent those unnecessary trauma. So anyway, but then to apply that for antibiotics, obviously we need to ensure that we still can achieve good concentrations at the end, at the end of the dosing interval. And ceftriaxone is a very common drug that we use in this patient population. Obviously, we know it's broad spectrum, it's time-dependent killing, and it's predominantly eliminated by the kidneys and partially by the biliary route. It's highly albumin bound, and then the current recommendation is 1 to 2 grams daily. However, there is a study that actually suggested looking into 2 grams 3 times weekly, because in end-stage renal failure, you actually prolong the half-life. You actually get a reduction of ceftriaxone clearance. So therefore, you might be able to prolong that prolong that therapeutic concentration in the patient's blood. Excuse me, can you give me a second? I think I'm just showing, I'm showing the wrong presentation.
Just while Danny's preparing his slides, this is a good opportunity for me to just remind everyone and the people who've just come on about our CRE Respond education program. All of our education program, we've got many seminars through to the rest of the year. All of our education program is recorded and on our YouTube channel. So you're free to access older presentations as well as ones you might miss. Okay, fire
Thank you,
away,
Susie.
Danny. No problem.
Yeah, really sorry, very embarrassing. I had two files open at the same time. So anyway, so that's why. So we decided to look at the population pharmacokinetics of a 3 times weekly post-dialysis ceftriaxone regimen, in this patient population. And then so the methods, basically we carried it out in a dialysis unit of a remote hospital, and then we recruited patients that are put on this regimen, and then we collected a series of blood plasma samples over 2 dosing intervals if possible, and then they're assayed, and then we construct a PK model, and then we did some dosing simulations. So essentially, the results, we obtained 244 samples from 16 patients. And then we found that a 2-compartment model with a protein binding exchange adequately describes the data. So you can see that, these concentration time graphs with the lines representing the model. You can see that the lines are very closely related to the crosses. So the crosses are the samples that we have obtained. So looking at these individual graphs, you can see that the model can describe the pharmacokinetics of this patient population fairly well. So when we construct the model, this is a very interesting study, well, to me anyway, because there are quite a few things that we need to consider. So the number one, we need to consider, we're going to use 1 compartment, 2 compartments, or 3 compartments, and eventually we selected a 3. When you just look at the differential equations, it looks like a 3-compartment model, but technically speaking, it's a 2-compartment model, but with a protein binding exchange within it, within the central compartment. And because of the high abdomen binding ratio of ceftriaxone, it's important for us to be able to describe that protein binding. So this particular model has been adapted from a study that was previously published by Dr. Burns on tacoplanum. And then the second thing that we need to think about is the protein binding. So we ended up using a complex protein abdomen binding model. And then as you can see on the right, like the protein binding, it's dependent on a few different factors, including the abdomen level and also the number of protein binding sites on the abdomen for ceftriaxone. We also have to factor in the molecular weight of ceftriaxone and the albumin, right? And then basically we just put that in. So the protein binding compartment, or the protein binding exchange, we put it as the 2nd compartment here. And then the third thing we need to think about is the dialysis session. So we need to be able, because these patients are on intermittent hemodialysis, so normally that's 3 times a week with an interdialytic interval of about 48 and 72 hours. In past studies, they have actually reported that dialysis does not enhance ceftriaxone clearance, but we don't want to take it lightly. So we still incorporated dialysis sessions into our model to see that, to validate whether dialysis really affect the pharmacokinetic model, whether it will affect the clearance of ceftriaxone. So what we have done is we used dialysis as in covariate. So you can see that the dialysis covariate here. So when it's 1, it means dialysis is on, and when it's 0, it means dialysis is off. So basically, we use selective execution of a logical expression statement. So you can see it here, means that the clearance of ceftriaxone, it's normally a CLNHD by the bilirubin covariate, which we'll talk about later. However, when HD equals 1, so which means that when dialysis is on, then the clearance is CLHD. So by using this expression, like P metrics will know to separate out the clearance during dialysis and when dialysis is off. Right, covariates. In the study, we found that the only covariate that's significantly associated with ceftriaxone pharmacokinetic parameters is serum bilirubin level, which actually made sense to us because we said that ceftriaxone is predominantly cleared by the kidneys or by the biliary route. So when the kidney route is minimalized, then the biliary route will take on the heavy duty of clearing out ceftriaxone. So in that setting, when the kidney route is blocked out and the biliary route is also blocked out, then your clearance will drastically reduce, and that's represented by this table here, which shows the relationship between serum bilirubin concentration and ceftriaxone clearance. And you can see that this relationship is actually an inverse powered relationship. Even when we removed this outlier point at around about 70 in terms of serum bilirubin concentration, the relationship is still really strong. The R squared is still 0.70. Okay, so and then it significantly improved our model. Right, so when we talk about the simulation, so the target that we use, is free drug concentration above the target MIC 100% of the last 24 hours of a 72-hour dose interval, right? So this is really important because we can't just go by a normal dosing interval, because for a patient on intermittent hemodialysis, a dosing interval can be as long as 3 days. So that's why we selected the last hour of a 72-hour dose interval. So that is our worst case scenario. And we chose the target MIC as 1 because 1 is the highest clinical breakpoint of all the common bacteria that we try to target. So in our case, you can see that looking at the 2 grams 3 times weekly regimen, like for someone without raised bilirubin, we can see that the PTA is 98.1, and the usual PTA target is 90. But because renal patients on hemodialysis, they are very, very vulnerable. They usually come with many chronic comorbidities. So that's why we set our target as 95%. But then this still actually exceeds it quite significantly. Right, we also looked into toxicity, and because this is something that is not as well described, and then basically we look at the chances of achieving toxicity level, and the most commonly agreed toxicity concentration for ceftriaxone is actually a C minimum of 100. And you can see on day 3, with a 2 grams 3 times weekly regimen, the chances of reaching toxic concentration is actually 0 until when you have fairly high bilirubin concentrations. But when you look at the daily regimens, which is the currently recommended regimens, you can see that the chances of reaching toxicity level is actually significantly higher. And that's only day 3. But when you look at day 7, you can see that the chances of reaching toxic level is very, very, very high for the conventional dosing. So so that's why we did some simulations looking at slightly reduced doses, 3 times weekly regimens. We see that when the bilirubin is only 10, your PTA for a 1 gram 3 times weekly regimen is actually 99.6. So that's why we recommended to use this reduced regimen when your bilirubin is greater than 10, right? So lastly, I want to talk quickly about dialysis clearance of ceftriaxone, because as I said before, previous studies have reported that ceftriaxone is not, its clearance is not enhanced on dialysis. But in our study, we show at least a 10-fold increase in ceftriaxone clearance, and you can see here, so clearance of clearance off dialysis and clearance on dialysis, there's a 10-fold difference. And this is actually shown on our simulation as well. And then we also simulated what would happen, what is the PTA when ceftriaxone is given on dialysis. Remember, because it's been reported that ceftriaxone is not cleared on dialysis. So all the international guidelines are saying that ceftriaxone can be given during dialysis. And that's actually standard practice for a lot of dialysis centers. But what we find is that if we do that, then the chances of hitting our target is almost zero. Right, so this is a huge discovery, and I looked in, so I sort of did some literature review to see why this is the case, and I realized it's because all the previous studies that reported that ceftriaxone is not cleared on dialysis, it's because they're using low flux dialyzer, but no one uses low flux dialysis nowadays. But this practice, this recommendation just has been carried through. Anyway, so in conclusion, we found that a 2 gram 3 times weekly post dialysis ceftriaxone regimen can be recommended for common bacterial infections. Administration during HD is not recommended. When you have patients with hyperbilirubin anemia, you can consider 1 gram 3 times weekly post HD regimen. Right, thank you very much for your attention, and sorry about the stuff up earlier.
Thank you, Danny, for a great presentation. I wonder if anyone from the public has any questions for Danny?
Thank you, Danny. It's Fakade here. Nice presentation.
Thank
I
you.
was wondering about the structure of your covariate model. So you're mentioning that ceftriaxone is predominantly renally eliminated, but I don't see any renal covariate in it. So the bilirubin, of course, to some extent is included. I hope I thought maybe there's something to, if you can reflect on this one. And the other question I have is also when you use your if condition for your dialysis clearance. So are we assuming that there is no residual non-renal or renal clearance and non-renal clearance in addition to the clearance by the machine itself? So why didn't we try to incorporate the residual non-renal clearance and renal clearance in addition to clearance by the machine? Thank you.
Okay, thank you very much, Fakadi. So we didn't incorporate renal function into this into our model. It's because all of our patients have end-stage renal failure. So in general, the renal clearance of ceftriaxone in this patient population is negligible. So you can still have some residual renal function in end-stage renal failure, but they are very, very small. So when so in these patients, when you go and collect their urines, you're looking at probably about 20 or 50 mils of urine every single day. So obviously, yes, you do still clear some ceftriaxone that way, but not significant enough to affect the model significantly. And another thing is that it's extremely difficult to measure residual renal function in this patient population. And to answer your other question about whether to incorporate non-renal clearance during dialysis, we have tried. We've actually tried quite a few different models to try to incorporate that. But then I think in absence of when bilirubin plays a huge part in non-renal clearance when renal clearance is negligible. But however, when renal clearance is present, then bilirubin clearance becomes more negligible. And in our case of dialysis, like when the dialysis is on, the half-life of ceftriaxone during dialysis has reduced down to about 3 hours from 10 to 15. So the dialysis clearance is much stronger than the biliary clearance. I wonder if that's actually one of the reasons why this is actually the best model we can that actually describe our data the best, because we've actually tried that model that you have suggested, and it turns out that it's easier to just lump them all together as a CRHD. Yeah.
There's one more question for you, Danny.
Oh, cool.
A very quick question. Hi, I'm Martha.
Hi, Martha.
I have a question regarding the bilirubin. I assume these patients were cirrhotic patients. Did the bilirubin have any effect on the protein binding of ceftriaxone? Did you test that?
Thank you, Martha. So number one, so these I think this is an incidental finding. Like none of our patients has cirrhosis. So all the patients with raised bilirubin are due to sepsis or some kind of severe infection. Like we did some literature review to look into the effect of bilirubin binding and competing with ceftriaxone binding, and we find, and the literature review, through the literature review, we've actually found that ceftriaxone has much higher affinity to albumin. So we found that there's no competitive binding issue there.
Right. Thank you, Danny.
Okay. Thank you.